A good day to everyone. So today we are going to continue our discussion for eye disorders. And now we are with the topic of retinal disorders. So this is referring to the retinal layer of our eyes. So we have different types of retinal disorders that we have for today. And the first topic that I am going to discuss would be retinal displacement. But before that, retina is composed of multiple microscopic layers. So we have the sensory retina, which is the innermost layer that contains the photoreceptor cells, the rods and cones, and the retinal pigment epithelium, the PRE, which is the outermost layer that captures impulses generated by the photoreceptor cells. So the sensory layer is the one that will um, receive the light, the the vision that we currently see right now. It's the one that receives it and transmits it to the brain for interpretation. So that's what our retina does. Now, for for the first disorder that we have, which is retinal detachment, as you can see here from this illustration, this refers to the separation of the retinal pigment epithelium, the RPE, from the sensory layer of the eye, of the inner eye. So there are four types, but what is causing this first? For retinal detachment, this usually is caused by any traumatic blow to the head. So for example, you've experienced a traumatic blow, you went into a fight with someone and somebody hits you so hard on the head, most especially near the eye area. This can happen. Retinal detachment. And there are four types of retinal detachment, which is we have Rhegmatogenous, traction, a combination of both Rhegmatogenous and traction, and Exudative. Now we first talk about Rhegmatogenous type of retinal detachment. So a hole or a tear develops in the sensory retina, allowing, as you can see here, there's an irregularity in the shape of the eyes of the patient, allowing some of the liquid vitreous to seep through the sensory retina and detach it from the RPE. So people at risk for this are those who have myopia, like me, aphakia after those who have undergone cataract surgery. They might experience this as well, or even trauma to the head can cause this to happen. Traction. So the tension or pulling force is responsible for traction retinal detachment. So let's say, for example, the patient has diabetic retinopathy. And these kind of condition, we have that topic later on in this lecture, diabetic retinopathy. With this condition, there will be a development of fibrous scar tissue, which will in turn cause the separation of the retina from the sensory layer. So if that happens, of course, if there is the growth of that scar tissue, it will push the retina to be detached from the sensory layer. So that fibrous scar proliferation exerts rather a pulling force into the delicate retina. So either it can be caused by diabetic retinopathy, vitreous hemorrhage, or retinopathy of prematurity. So that is for the traction. Both is, of course, the description of both would be for the description of both Rhegmatogenous and traction. Now, for exudative retinal detachment, this is the result of the production of serous fluid under the retina from the choroid. And the cause of this would be from uveitis because of inflammation, of infection, and of course also macular degeneration, which will cause the production of serous fluid inside the eyes. So that is for exudative retinal detachment because of either macular degeneration or inflammation. Now we go to the predisposing factors of retinal detachment. We have aging, so they are more susceptible in developing this. Those who just had a cataract extraction, degeneration of the retina due to aging as well, trauma, which is more common, or those with severe myopia, but I don't have severe myopia yet. I still have myopia, but it's not yet severe. Or those who have a previous retinal detachment, they're already susceptible in developing it again, and with a family history of retinal detachment. Now, clinical manifestations are the following. There may be a sensation of a shade or veil or curtain coming across the vision of the eye. So it will appear like this. There's a dark curtain over the field of the vision of the patient, or a presence of cobwebs, shadows, or black areas in the field of vision, or any bright flashing lights that they have in their field of vision, or a sudden onset of a great number of floaters, such as this one on the right side. So, aside from having a curtain of dark shadow appearing in their field of vision, floaters such as this might appear as well. So, diagnostic tests, either slit lamp by microscopy or fundus examination through ophthalmoscopy is going to be done. So, this is the slit lamp microscopy. And a slit lamp is a microscope with a bright light used during an eye exam, which gives the ophthalmologist a closer look at the different structures at the front of the eye and inside the eye. So with this alone, the ophthalmologists will be able to determine whether the patient has a retinal detachment or not, or through ophthalmoscopy as well, or also known as fundoscopy. So again, ophthalmologists are the ones who are going to perform this, not us. Surgical management is to do scleral buckling, wherein the ophthalmologists or the retinal surgeon compresses the sclera, as you can see here, often with a scleral buckle or a silicone band, to indent the scleral wall from the outside of the eye and bring the two retinal layers in contact with each other. Advantages, this procedure has a high success rate. There's less damage to the lens of the eye in patients and a low risk of endophthalmitis. Disadvantages, it will increase the incidence of double vision or diplopia and myopia, and it will cause increased post-op pain. So analgesics are very, very important post-operatively after doing scleral buckling. Pars plana vitrectomy, which is an intraocular procedure in which 1 to 4 millimeter incisions are made at the pars plana or the sclera, such as this one, as you can see here. One incision allows the introduction of a light source, based from this illustration, and another incision serves as a portal for the vitrectomy instrument, like what you can see here. The vitreous gel of the eye is removed and replaced with gas to refill the eye and reposition the retina. The gas eventually is absorbed and is replaced by the eye's own natural field. And usually after vitrectomy is done, a scleral buckle is also going to be performed. Another procedure done is the pneumatic retinopexy. So it's a technique used for the repair of Rhegmatogenous retinal detachment where a gas bubble or a silicone oil or a perfluorocarbon and other liquids may be injected into the vitreous cavity. So similar as pars plana vitrectomy, but other agents will be introduced. And this will help push the sensory retina against the RPE. So it's quite similar to pars plana vitrectomy. An argon laser photocoagulation or cryotherapy is also used to spot weld the small holes once after the procedure is done. So it's like welding the holes or patching it up with an argon laser photocoagulation or cryotherapy. Another procedure is transconjunctival sutureless vitrectomy, where it is a less invasive procedure where a 25 gauge technique allows for self-sealing transconjunctival pars plana sclerotomies. How do they do this? They will infuse a fluid through that 25 gauge needle secured by passing through a block of plastic sutured into the eye. So as you can see here, they are using a needle in this illustration. And a balanced salt solution is fed into the eye by gravity, and illumination and observation are provided with the indirect ophthalmoscope. Here, the vitreous is aspirated into the port of the sharp-tipped vitreous cutter. So that's the transconjunctival sutureless vitrectomy. Nursing management for patients who have retinal detachment. We need to instruct the patient to maintain a prone position to allow the gas bubble to float onto the position overlying the area of detachment, providing consistent pressure to reattach the sensory retina. That is after pneumatic retinopexy is done. Now, question. Sometimes they are asking this at the NCLEX or board exam. Once the patient is experiencing retinal detachment prior to surgery, where is the best place to position the patient? Is it affected or unaffected position? Here, we are going to place the patient on the affected side so that the retina that has detached will somehow go back to its original place. So we place the patient on the affected side. I repeat, affected side, not the unaffected side. Because the placing the patient on the unaffected side will further cause the detachment of the retina through the force of gravity. That's why we are placing the patient on the affected side. So that with the force of gravity, it will allow the retina to go back to its place. Teaching about complications. Since there might be an increased intraocular pressure, we advise the patient to avoid doing activities that will increase the intraocular pressure, such as coughing, sneezing, bending over. What else? Doing the Valsalva maneuver during defecation or bowel movement. Other complications would be endophthalmitis or infection brought about by these procedures. Development of other retinal detachments can occur. Development of cataracts and loss of the turgor of the eyes. And now we go to age-related macular degeneration, or AMD. It is the most common cause of visual loss in older people older than 60 years of age. It's part of the aging process. Clinical manifestations is it's characterized by tiny yellowish spots called drusen beneath the retina. If the doctor is going to visualize it with the same diagnostic procedures that I've mentioned during retinal detachment. Drusen are small clusters of debris or waste materials that lie deep within the RPE of our eyes. So there will be central vision loss, but they can retain peripheral vision. So this illustration here shows the drusen. And for patients who have macular degeneration, the central vision is the first one that is being lost. Types. We have the dry type or non-neovascular, non-exudative. It accounts for 85 to 90% of all cases of AMD, and the outer layers of the retina slowly breaks down and come the appearance of the drusen. Well, the wet type or neovascular, the exudative type, it has an abrupt onset, and there is a proliferation of normal blood vessels growing under the retina. Within the choroid layer of the eye, a condition known as choroidal neovascularization will occur. And the affected vessels now, they can leak fluid and blood, which will elevate the patient's retina. So patients who have this condition may report that straight lines appear crooked and distorted, or that letters in words appear broken. This is for the wet type of AMD. So look at this picture here. If these lines will appear crooked, as you can see here in this picture, it means that they might be having the wet type of AMD. So medical management, there's no cure for this. Use of antioxidants such as vitamin C, vitamin E, beta-carotene, zinc oxide, lutein, zeaxanthin, or carotenoids have shown to slow down the progression of AMD. So they need to eat fruits that are high in vitamin C, vitamin E, the orange type of fruits and vegetables are the ones high in beta carotene, like carrots and others. They need to eat those type of foods. We need to teach those to the patient. What else? Anti-angiogenic therapy, agents that inhibit the ability of vascular endothelial growth factor, or VEGF, to bind to cellular receptors. Because the vascular endothelial growth factor is a stimulus for the development and progression of angiogenesis, which is the abnormal blood cell formation inside the eyes of patients with AMD. So the VEGF antagonist, the drug of choice for that would be ranibizumab or Lucentis, or a monoclonal antibody known as bevacizumab or Avastin. These two drugs will be helpful in order to prevent the development and progression of angiogenesis. Our nursing management is, after patient discharge, instruct our patients to monitor for sudden onset of distortion of vision. Ampular grids, as you can see here in the illustration, may provide the earliest sign that macular degeneration is getting worse, because they can see that these straight lines will appear crooked. So they need to look at these grids one eye at a time and several times each week with glasses on. If the lines or squares appear distorted or faded, they need to notify their ophthalmologist immediately for the appropriate treatment to be done. Now, lastly, we go to diabetic retinopathy, which is a complication of diabetes that affects the eyes caused by damage to the blood vessels of the retina. Ocular manifestation of this is the ocular manifestation of the systemic disease known as diabetes mellitus. The longer that you have DM and the less that you are controlling your blood sugar, the more likely that you will have diabetic retinopathy. Aside from having the other complications of diabetes mellitus as well, such as nephropathy, diabetic nephropathy. Manifestations: at first, no symptoms or only mild visual problems may be exhibited by the patient, but eventually, patients who have diabetic retinopathy will progressively be blind. So to protect vision, we need to advise patients who have DM to carefully control their blood sugar level and have a yearly eye examination. That's the most important thing in order for diabetic patients not to develop complications of DM, such as diabetic retinopathy. And there's two stages of this, two types, with the non-proliferative NPDR and the proliferative diabetic retinopathy. And we start out with the non-proliferative type. It's the earliest type of diabetic retinopathy. New blood vessels aren't growing yet, but the walls of blood vessels in the retina will weaken. So once this weaken, microaneurysms protrude from the blood vessel wall, sometimes leaking or oozing fluid or blood inside the eyes. The macula will begin to swell, and it will further cause macular edema that can be seen through ophthalmoscope. But that is already observed by ophthalmologists. For the proliferative, this is the late stage now, advanced and severe form. New blood vessels begin to grow inside the retina, and these blood vessels are abnormal. They may grow or leak into the clear jelly-like substance that fills the center of our eyes, which is the vitreous humor. So the pathophysiology of this is there's increased sugar levels in the blood. These tiny blood vessels become blocked or damaged. Blood supply to the retina and will be cut off, leading now to vision loss. And the eye will attempt to grow new blood vessels, which are abnormal blood vessels. And these blood vessels will leak and create hemorrhage, further complicating things for a patient who have diabetic retinopathy to have vision loss. Clinical manifestations has no signs and symptoms until the damage is already severe. Blurred vision will occur and slow vision loss will progress over time. Floaters such as this will appear in the patient's visual field as well, or shadows or missing areas of vision may be present, and they will be experiencing night blindness, trouble seeing at night. Management, of course, it's very, very important to teach the patient to control blood sugar, blood pressure, and cholesterol levels, most specifically the blood sugar. By what? By religiously taking their oral hypoglycemic agents or taking insulin every day. We should also stop smoking. Non-proliferative type may not need treatment, but they should be closely monitored. Treatment does not reverse damage, but it can help keep the disease from getting worse. Because if they are already in the proliferative type, that will only get worse. So we are going to primarily do supportive treatment for patients who have this to slow down the progression. Complications, of course, vitreous hemorrhage. You will see that their eyes will become bloodshot as well due to the blood leaking into the vitreous humor. Of course, with those new blood vessel, abnormal blood vessels that are growing, retinal detachment is going to occur. Glaucoma will also be present, and of course, complete blindness will happen to a patient who has diabetic retinopathy. So that's it for the retinal detachment that you have for the eye. So if you have any question with regards to our lecture for the eye disorder, please do not hesitate to ask me about them. The next topic that we will have would be the different types of ear disorder. So again, thank you very much for listening for today's lecture. Have a great day and have a great weekend, everyone. Bye.